This is the fourth video of the abdomen series. In this video, I will be demonstrating the nerve supply of abdomen, the somatic and autonomic. In the somatic nerve supply, I'll be demonstrating the intercostal nerves that are supplying the abdominal wall, the branches of the lumbar plexus, ilioinguinal, iliohypogastric nerve, and then lastly the autonomic nervous system, the celiac plexus, superior mesenteric plexus and inferior mesenteric plexus, how they are formed and how they are distributed. The somatic nerve supply of the abdomen is derived from the lower intercostal nerves and branches of the lumbar plexus. The nerves coming from the lumbar plexus are the iliohypogastric, ilioinguinal, and the genital branch of genitofemoral, and these nerves are not visible here. These somatic nerves will supply the skin, superficial fascia, skeletal muscle of the abdomen, and the parietal peritoneum. The autonomic nerve supply for the abdomen comes from the sympathetic and parasympathetic nerves. The sympathetic nerve fibers originate in the thoracolumbar levels of the spinal cord. The parasympathetic nerve fibers comes from the vagus nerve and the pelvic splanchnic nerves from the sacral levels S2, S3 and S4. These autonomic nerves will supply all the viscera in the abdomen as well as the smooth muscles of the blood vessels. The functions of the parasympathetic and sympathetic nerves are antagonistic and balance each other. I am now going to demonstrate the somatic nerves on the posterior wall of the abdomen. In this cross-section, the abdominal viscera have been removed. The lower intercostal nerves are the ventral rami of spinal nerves T7 to T11, and we have already seen these in the thorax prosections. They are not visible here, but will course infrolaterally in this direction along the posterior abdominal wall. Now I am pointing to the 12th rib. Inferior to this is the subcostal nerve. This travels in the same direction as the intercostal nerves. Similar to the upper thoracic spinal nerves that innervate the thoracic wall, the lower intercostals and subcostal nerve gives off lateral cutaneous branches around this area and terminate in anterior cutaneous branches in this area. Each intercostal has a band-shaped dermatome. Importantly, the T10 dermatome includes the umbilicus and the L1 dermatome covers the pubic region. The motor fibers of the subcostal and lower intercostal nerve also supply the four muscles of the abdominal wall as shown in video 1. This is the iliohypogastric nerve. It comes from the ventral ramus of L1. The sensory distribution of this nerve is the skin over the pubic region. Its motor fibers also innervate the muscles of the abdominal wall. This is the ilioinguinal nerve. It also comes from the ventral ramus of L1. It runs over the iliac crest, passing parallel to the inguinal ligament, and travels through the inguinal canal in this area. Its sensory fibers supply the skin over the anterior part of the scrotum and root of the penis in males or labia majora in females. The motor fibers innervate the muscles of lower abdominal wall. This nerve over the iliacus muscle, coursing along the iliac fossa, is the lateral cutaneous nerve of thigh. It receives contribution from L2, L3 spinal levels. Like its name suggests, it supplies skin over the lateral side of the thigh. I will now show the relationship of the few of the nerves of the lumbar plexus to the psoas major muscle. Starting on the medial crease of psoas muscle, this is the obturator nerve. It travels along the pelvic brim and enters the obturator foramen. This is the genitofemoral nerve coming from the L1-L2 spinal levels, lying on the surface of the psoas muscle. It divides into two branches, a genital branch and a femoral branch. The genital branch of this nerve supplies the cremastric muscle of the scrotum in males, and a sensory branch that supplies the anterior part of the scrotum. This is responsible for the cremastric reflex, as mentioned earlier in video 1 of the abdominal series. The cremastric reflex tests the L1 and L2 spinal levels. During this test, stroking the medial side of the thigh causes the retraction of the ipsilateral testicle. The femoral branch of the genitofemoral nerve provides sensory innervation over a small area of the anterior thigh. Finally, this important thick structure on the lateral crease of the psoas muscle is the femoral nerve. It gives sensory and motor innervation to the anterior compartment of the thigh. Before I introduce you to the autonomic plexus of the abdomen, let me describe the sympathetic and parasympathetic nerves, where they originate, where they are distributed, and how they reach the specific viscera in the abdomen. Sympathetic nerves originate from the spinal cord in the T1 to L3 level. On this cross-section of a spinal cord at thoracic level, the cell bodies for these sympathetic fibers are here at the lateral horn. The preganglionic fibers then pass from the ventral root and reach the spinal nerve. These fibers will pass to the sympathetic chain via the white rami communicans. The right and left sympathetic chains runs on the either side of the vertebral column, and each consists of chains of ganglion connected by nerve fibers. The chain extends from the skull to the coccyx. There are 3 cervical ganglia in the neck, 11 thoracic in the thoracic cavity shown here, 4 lumbar in the abdomen, and 4 sacral in the pelvic cavity. Here on this model of the pelvis, we can see the lower part of the right and left sympathetic chain with sacral ganglia. These 2 chains meet at the coccyx, and the united ganglion is called as ganglion impar. I would like to introduce the splanchnic nerves before I demonstrate the greater, lesser, and least splanchnic nerves. The word splanchnic means hollow viscera, and they are called this because they supply all the viscera in the abdominal and pelvic cavities. They always carry exclusively autonomic fibers. There are thoracic splanchnics, lumbar, sacral, and pelvic splanchnics. The thoracic, lumbar, and sacral splanchnics carry sympathetic fibers, while the pelvic splanchnics carry parasympathetic fibers. Here is the greater splanchnic nerve. It is formed by multiple contribution from the sympathetic trunk from cord level T5 to T9 inside the thoracic cavity. It passes through the crus of the diaphragm. Its preganglionic fibers synapse at the celiac ganglion and other unknown ganglion in the celiac plexus. It innervates the walls of the abdominal aorta and the viscera that are supplied by celiac plexus. The lesser splanchnic nerves are formed by the contribution from T10, T11 parts of the sympathetic trunk inside the thoracic cavity. It also passes through the crus of diaphragm and contributes to the celiac plexus. The least splanchnic nerves are not visible here. They come from the T12 level of the sympathetic chain. They contribute to the renal plexus. The lumbar splanchnics coming from the lumbar part of the sympathetic trunk are not visible here. These are the sacral splanchnics coming from the sacral part of the sympathetic chain, and these contribute to the superior and inferior mesenteric plexus. They also contribute to superior and inferior hypogastric plexus. Let me demonstrate the pelvic splanchnic nerves on this pelvic model. The pelvic splanchnic nerves, sometimes referred as nervi erigentis. These are very special because they are the only splanchnic nerves that carry parasympathetic nerve fibers. Another important feature I would like to show you that these nerves do not originate from the sympathetic trunk, but rather from these ventral rami of S2, S3, and S4. Let me show you the origin and the course of the parasympathetic fibers on this model. The cell bodies lie here in the gray matter of the S2, S3, S4 levels of a spinal cord. The preganglionic parasympathetic fibers leave the spinal cord via the ventral root and reach the spinal nerve. Then they travel through the ventral ramus of the spinal nerve and leave it as the pelvic splanchnic nerves. They contribute to form the right and left hypogastric plexus. In the abdomen, the pelvic splanchnic nerve contributes the parasympathetic innervation to the inferior mesenteric plexus, which supplies the hindgut-derived structures. Clinically, these pelvic splanchnic nerves are very important because damage to these can lead to bladder and rectal incontinence and sexual dysfunction in males. This will be demonstrated in the pelvis and perineum video. On this prosection, I am going to demonstrate the pre-aortic autonomic plexuses. These supply the gastrointestinal tract and the associated structures. These plexuses are not present here, but I will show you the position of each plexus. There are the celiac plexus, superior mesenteric plexus, and inferior mesenteric plexus. The celiac plexus is situated around the root of the celiac trunk. It receives sympathetic innervation from the thoracic splanchnic nerves and parasympathetic innervation from the right and left vagus nerves. On this model, here is the celiac trunk. These white lines represent the celiac plexus around the artery. The branches from the celiac plexus course along with the branching of the celiac artery. Therefore, the plexus innervates the stomach, part of duodenum, and pancreas. It also innervates liver, gallbladder, and spleen, not visible here. This is the superior mesenteric artery, and the superior mesenteric plexus is situated around it. It receives parasympathetic innervation from the vagus nerves and the sympathetic innervation from the lumbar splanchnics. The nerves from this plexus innervate the midgut derived structures. So it supplies the duodenum, jejunum, ileum, cecum, ascending colon, and the right two-thirds of the transverse colon. This is the inferior mesenteric artery, and the inferior mesenteric plexus is situated around here. It receives parasympathetic innervation from the pelvic splanchnics. The sympathetic innervation comes from the lumbar and sacral splanchnics. This plexus innervates the hindgut-derived structures. Therefore, it innervates the left one-third of the transverse colon, descending colon, sigmoid colon, and the upper part of the rectum. Note that the parasympathetic innervation to the right two-thirds of the transverse colon is provided by the vagus nerve, and then the parasympathetic innervation changes to pelvic splanchnics in the left one-third of the transverse colon. Let me talk about the concept of the referred pain. Referred pain can be described as when pathology is in one region of the body and the pain is experienced in another region of the body. For example, gallbladder pain, which is referred to the right shoulder. The basis for this pain is because of the involvement of the parietal peritoneum in the area of the gallbladder. In this region, the parietal peritoneum is supplied by the right phrenic nerve from spinal levels of C3, C4, C5. The nerves from this level of C3, C4, C5 also supply the skin around the right shoulder. When the gallbladder becomes inflamed, it will irritate the visceral peritoneum covering it, and also may progress to irritate the parietal peritoneum surrounding it. The sensory fibers carrying the pain from this area of the parietal peritoneum will enter the spinal cord from the same dorsal root where the sensory fibers from the shoulder region of C3, C4, C5 are entering. The central nervous system confuses this information, and the patient feels the referred pain in the shoulder area while their pathology is in the gallbladder in the right hypochondric region. Now I will explain the difference between somatic and visceral pain with the example of appendicitis. In appendicitis, there is dull pain at the onset, and then it becomes sharp and excruciating at later stages. The reason for this is that initially when the appendix gets inflamed, it involves the visceral afferent nerves from appendix and its visceral peritoneum. These nerves carry the pain to the central nervous system, and that is perceived as dull, vague pain around the umbilicus. As the inflammation progresses, it starts involving the parietal peritoneum overlying the appendix. This peritoneum is supplied by somatic nerves. Once these nerves are involved, the characteristic of the pain changes to sharp, excruciating, and becomes localized to the area around the appendix, which is clinically known as McBurney's point on the surface of the abdomen.